Thank you. So good afternoon, everyone. Our topic for today was one of the topics that was submitted when we requested topics from the broader community. So it was a request to look at phentermine's use in the treatment of obesity. Objective-wise, what I hope to accomplish over the course of the next few minutes is to describe the pharmacology of phentermine. So why are we using this for the treatment of obesity? We're going to evaluate some of the literature support. Now, this I thought was going to be the bulk, and I really didn't expect it to be as challenging as it was. So we are going to look at some of the literature related to phentermine use alone for treatment of obesity, but we're also going to look at phentermine topiramate combination use because those are three of the more recent studies that are available. And they provide a lot more of the data that is out there in the published work. There's a lot of reviews for treatment of obesity. There wasn't nearly as much primary literature, so I was a little disappointed. And then we're going to hit on some of the adverse effects that patients who are taking phentermine or phentermine combination products do experience. So I wanted to get my disclosure in there just in case you were thinking it was going to be phentermine only. So thinking about obesity, I wanted to start with definitions. So just as a reminder, the World Health Organization's definition for overweight and obesity is abnormal or excessive fat accumulation that contributes to risk for health conditions. Overweight body mass index are BMIs of 25 or above. Obesity technically starts at a body mass index of 30 or above. We are going to have some patients that fall into this obesity plus category. So individuals who are overweight have a BMI of 27, but do have existing comorbid conditions. So health conditions that put them at increased risk. So even though they're not technically obese, they are going to be included in, I think, almost all of the trials that we're going to talk about today. So I did just want to give you that disclaimer. The other thing that I think is important, I like to point out to students, and I don't have any who are on the call with us today, as they're looking at the primary literature, the difference between statistical significance and clinical significance. We're going to see that there are quite a few trials that demonstrate a change in weight, but it's important that the change in weight is actually clinically significant. In terms of weight reduction, reductions of 5 to 10% from baseline are considered clinically significant. It seems to reduce the risk of other conditions, including cardiovascular disease. It also can delay or prevent the diagnosis of diabetes, specifically type 2 diabetes. So 5% really is that threshold. I wanted to be clear about that because that was the threshold I used throughout the rest of the presentation. There are some individuals that suggest there are health benefits with as little as a 3% reduction from baseline, but we're going to use the more standard 5%. All right, let us get started now that the definitions are done. So our focus today is on phentermine. So phentermine itself has been around for quite some time. It goes by a number of different brand names. There were 4 or 5 other brand names that were listed. Not all of them have been available here in the United States. Adipex and the Lomira are the 2 that are primarily available currently. Fastin was the next most common that popped up, but that actual brand product is not available, even though the phentermine generic is available. These medications are controlled substances. So they are listed as Schedule 4 controlled substances. They're available as tablets and capsules, and their official indication is for short-term adjunct treatment in the management of exogenous obesity for patients with a BMI of 30 or greater, or 27 or greater with risk factors, specifically, excuse me, hypertension, diabetes, or hyperlipidemia. So kind of that I said obesity plus, I guess it's overweight plus. So that BMI of 27, which isn't quite to the obese category, but with those additional risk factors. Now, short term was not specifically defined in what the FDA prescribing information has, but just that it was not supposed to be a long-term fix. So how does this work? Phentermine is a sympathomimetic amine. It's believed to increase norepinephrine release in the hypothalamus, causing a suppression of appetite. It's categorized close to amphetamines. So it's really within that cohort of type of medication. So more on the stimulant side of things. It doesn't seem to have as much of an impact on dopamine, which may be why it doesn't have quite the reward effect that the amphetamines do have. Thus, it's also a Schedule 4 and not a Schedule 2 like the mixed amphetamine salts are. So the thought is really to change some of the chemicals which drive the appetite in patients. But it's contraindicated in a number of places. So norepinephrine is not just involved in appetite. It's contraindicated in patients with a history of cardiovascular disease, those that have used monoamine oxidase inhibitors within the last 2 weeks, those with hyperthyroidism, glaucoma, in agitated states. I kind of like that one. I did some digging to try to figure out what exactly agitated state was, because I feel like I'm in agitated state sometimes. But it really was unclear exactly what that referred to. Drug abuse, pregnancy, patients who are nursing, as well as a hypersensitivity to phentermine. So it does have some restrictions in terms of who this could be used in, recognizing that we're hoping to use it in patients who are obese or those that have a BMI of 27 or greater that have some medical conditions. This really does limit. We're not able to capture all of the patients within that particular cohort. So seeing that, I was really hoping to dive into the literature, and I try to work smarter, not necessarily harder. So I wanted to start with the clinical trials that got these products approved. Oh, actually, I have one thing before that. I have a funny story about the next slide, which is where that was coming from, but I forgot I had added this in here. One of the things, because there is some restrictions, there was concern, especially about some cardiovascular findings, some pulmonary hypertension issues when phentermine had previously been used with fenfluramine, so another diet medication. There really had been a lot of restriction on the use of phentermine. As of February 23rd of this year, there were some adjustments in how robustly the phentermine can be used. So the administrative code was revised. Controlled substances can be used for the treatment of obesity, specifically Schedule 3 or 4, if the medication has an official FDA-approved indication, which phentermine falls into. But the continuation piece, so the actual FDA approval says short term, this adjustment to the administrative code allows for continuation of the prescription beyond 3 months. So really opening that up for longer term treatment with phentermine, as long, there are a number of categories. They need to be monitored. They're watching the ORs, no misuse, no use of other controlled substances. But the big caveat with this is that it has to be effective. So continuation beyond that 3-month time frame has to be in patients who are able to maintain a 5% weight reduction from baseline, so that they had to have that improvement. And that also is why I really utilized that as our threshold. So recognizing that we're looking to use this much more robustly, I was hoping, again, to work more efficiently. So I wanted to start with the prescribing information. The clinical trial data is usually in the prescribing information. For both of these brand name products, the prescribing information for the clinical trials has this quote. It is exactly the same on both of them. The magnitude of increased weight loss of drug-treated patients over placebo-treated patients is only a fraction of a pound a week. The rate of weight loss is greatest in the first weeks of therapy for both drug and placebo subjects and tends to decrease in succeeding weeks. That's what it says for the clinical efficacy information. I was shocked and a little bit disappointed because I was really looking for the actual data. So there have been some suggestion that there is a tolerance to the weight loss effects, especially with phentermine, being that it is sympathomimetic, kind of somewhat amphetamine-like. But I was able to find some data, especially some longer-term data with a combination product that really may challenge some of this information that's in the prescribing information. So let's look at what we were able to find. Drugs are approved by the FDA. They need at least 2 double-blind placebo-controlled trials. Some of them use active comparator if it's unethical, but they're really looking, the drug has to be better than placebo. That's what the FDA, and it has to be safe. That's what it's establishing its guidelines on. Some of our older medications, phentermine being included, not all of those results are published and widely available, because I looked and I searched and I was trying to uncover where they were. So the information I was able to find on phentermine's efficacy for treatment of patients who are obese or those that are overweight is going to be in 3 different categories. And I do recognize that it's subsets of patients, so it is not broadly generalizable. And that's why I included the information with the combination products. So that's my disclaimer for the strength of the evidence we're about to look at. So this first trial was a retrospective review. It was done in an endocrinology clinic. They included women who were 18 to 45 years old, who were having infertility issues and were obese and were given a prescription for phentermine. The prescriptions for the women, all of them were for 18.75 milligrams daily for a week, and they could titrate up to 37.5 milligrams daily. The women, their average age was 34 years. They were included if their BMI was at least overweight, so at 25, but the average BMI was in the obese category, so the average BMI was a 36. Individuals were using the phentermine. The mean duration of use was 70 days. 80% of the women that were included, and there were 65 women that were included, used it for at least a month, and about 42% used it for more than 90 days. So they had a little less than half that continued to use it for more than 3 months. And this was just the retrospective chart review. They were just looking at the information that they had. So compared to before the patient started the phentermine to their follow-up after they were using the phentermine, the mean weight change that they saw 3 months later was a reduction of 5.2 kilograms. So a little more than 10-pound reduction over the course of 3 months. When they looked at the weight change from baseline, almost 50% of them lost 5% of their body weight compared to baseline at 3 months. So almost half of them were there. And when they followed them out for 6 months, more than a third of them were able to maintain that loss up to that 6-month time frame. So it did look like the phentermine was effective for these patients and that they were able to sustain that weight loss. So challenging a little bit that description that the weight loss is only effective initially. It looks like maybe we see the weight reduction initially, but they're able to maintain at a lower level for an extended period of time. It was relatively well tolerated. Constipation and headache were 2 of the most common adverse effects. The secondary outcome for this particular clinic was to reduce weight in these women and ultimately allow them to conceive because they did have infertility. With the individuals who were included and were given phentermine, 60% of them were able to go on to conceive without requiring in vitro fertilization or other methods to conceive. So it was thought to be effective not only for weight loss, but also to assist with kind of resetting some of the other metabolic processes for these women. So that was only in women though. So I was still searching to try to find other information. This was an open label trial. It was called a phase 4 trial for patients that are in Mexico. So again, the generalizability a little bit different. These were all adults that were obese. Their BMI had to be over 30. They were able to have comorbid conditions. Hypertension, dyslipidemia, and diabetes were the most frequent, along with osteoarthritis. They were prescribed Phentermine. They were on it for at least 6 months. 400 of the patients were on 15 milligrams, and 532 of the patients were on 30 milligrams. When they looked at the mean weight change at 3 months, so that 90-day time frame, there was a 4.5 kilogram reduction in the 15 milligram group and almost a 6 kilogram reduction in the 30 milligram group. So a little more than, or about 12-pound weight loss over the course of the 3 months. When they followed them out to the 6 months, it seemed to continue. So we had almost a 7 kilogram weight loss in the 15 milligram group and almost a 8.5 kilogram weight loss in the 30 milligram group. Because that threshold really with clinical significance is the 5% reduction in weight from baseline, the 15 milligram group had about half of the patients, so similar to what we just saw, even though the dose is a little bit smaller, but about half of them did reach that threshold at 3 months. And it was up to almost 77% in the 15 milligram group by 6 months. For the higher dose, it was 62% already at 3 months and up to 82% at 6 months. So again, they did see pretty robust reduction in weight that was able to be sustained past that 3-month time frame. For these patients, they also generally tolerated the medication fairly well. Constipation and insomnia were pretty common, were the most common adverse effects that were reported. I was able to find one more with just the Phentermine alone. So this is in a Korean population. So as I said, each of the cohorts was a little bit different. This was a randomized double-blind placebo-controlled trial. It was in patients who were overweight. They were not allowed to have diabetes. They could have dyslipidemia, but not high enough to be treated. And if they had hypertension, it had to be controlled with one medication. So they couldn't be on combination antihypertensive medications. This was more short-term. So this was only 14 weeks. And it was a little bit of a smaller cohort compared to the Mexican cohort we just looked at. So there were over 30 patients in each group, placebo and Phentermine. They only used the one dose. And what we see is the average weight change. So it was about a 7.5 kilogram reduction in the patients that were on Phentermine. And when we look at how many of them had that 5% weight loss, it was almost 88% of those patients were able to get that even at 14 weeks in the Phentermine group. When they looked at those that achieved a 10% weight loss, it was still over 50%. Interestingly, this group had significantly more adverse effects than any of the other clinical trials that I looked at. So more than 50% of the patients did report dry mouth. Insomnia, headache, and dizziness were insomnia, headache, dizziness, fatigue, and palpitations were reported in more than 20% of the patients. This is the only trial that had adverse effects reported that high. All of the other clinical trials, the percentages of the adverse effects were under 20%. So I did just want to point out, yep, we had some robust efficacy data here, but it looked like tolerability was a little bit different, even though they still had about 80% of the patients complete the 14 weeks. Now, since those were small, I really wanted to look more broadly at a larger group, a more generalizable group of patients in terms of, can this medication be effective for treatment of obesity? That's where the combination comes in. So the vast majority of literature that's out there, especially the more recent literature, is with the phentermine topiramate combination product. I recognize this is not just efficacy data for phentermine. The combination was put together so that lower doses of both agents could be used. The thought is that they may potentially work synergistically and are better tolerated together. So there were 3 trials we're going to look at. So the EQUIP, the CONQUER, and then the SEQUEL were the 3 trials. This is the EQUIP trial, randomized double-blind parallel group, and it was over the course of a year. So 56 weeks, there was a run-in phase, and then patients were followed for the vast majority of the year. Patients had to have a BMI of at least 35. They could be on 1 of 2 doses of phentermine topiramate, so the 3.7523 or the 1592, and then or the placebo group. So they had more than 1,000 patients that were enrolled. And as we look at them, the percent that had the 5% weight loss compared to baseline, so that clinically significant threshold, it was 66% of the higher dose group and about 45% of the lower dose phentermine group did reach that threshold. So again, a fairly robust number of patients were responding. As they continued to dig down, they actually had almost a third of patients on the higher dose group lose 15% of their body weight compared to baseline at the end of the 56 weeks. Overall, the medication was relatively well tolerated. Again, there were no adverse effects that were reported in more than 20% of patients. Paresthesia, dry mouth, and constipation were the most frequent. But the dropouts were exactly the same between the active and the placebo group. The second trial, the CONQUER trial, also double-blind placebo-controlled for 56 weeks, set up very, very similarly to the other trial. From a logistic standpoint, from a population standpoint, they expanded it. So they allowed for patients with a BMI of 27 or greater, and it could go up to 45. These individuals could have a comorbidity. They could have elevated blood pressure. They could be on up to 2 antihypertensive medications. They could have elevated triglycerides and be on at least 2 dyslipidemia medications. They could have elevated fasting blood glucose, impaired glucose tolerance, and they could have diabetes if it was controlled with either lifestyle modifications or metformin. So they didn't want patients on other diabetes interventions. They were split into 2 groups, so placebo and again 2 doses of the phentermine topiramate. As we look at the 5% reduction, so 70% of that higher dose were able to achieve that 5% reduction in weight compared to baseline. 62% in the lower dose group were able to reach that threshold as well. When they looked at 10% reduction, it was almost half of that high dose group. So it did look like this was effective over the course of a year. They also had less than 20% adverse effects. Dry mouth, paresthesias, and constipation were the most frequent in that trial. The investigators then wanted to look at an extension. So they took the folks that were in that prior trial and offered a double-blind placebo-controlled extension that went out for an additional year. So patients could be randomized either to placebo or to one of the 2 doses of phentermine topiramate. They were able to capture quite a few patients in this extension and over 80% of them actually went on to complete the full 2 years of treatment. When they looked at the least square mean body weight change from baseline, so on average, how much weight did they lose from baseline? For the phentermine topiramate group, it was over that 5% threshold. So for the lower dose group, it was maintained in this year 2 at about 9%. For the higher dose group, it was 10.5% reduction compared to baseline. So again, from a clinically significant standpoint. Side effects were paresthesias and dry mouth. Those were the most common. And when they looked at a number of the medical findings, so waist circumference, blood pressure, glucose, cholesterol levels, all of them also continued to trend down, which was in line with the amount of weight loss that the patients had. I spoiled the adverse effects. So yes, the phentermine works, whether it's alone or in combination, but it does have adverse effects. Those with the asterisks were the ones that were seen most frequently in the clinical trials. I do want to point out the paresthesia. That was the one that's not listed for phentermine that did show up in the phentermine topiramate group that likely is due to the topiramate. But overall, even though they had these adverse effects, most of the patients were willing to continue treatment. So just to wrap up, phentermine is effective at reducing weight in patients who are obese or those that may be overweight with a comorbid condition. We're looking at about half of between 40 and up to 80% of the patients are reaching that threshold of improvement with a 5% reduction in weight compared to baseline. That happened both in the monotherapy as well as in the combination therapy group, and they were relatively well tolerated. In the grand scheme of things, how does this compare to some of the other obesity treatments? So it is an oral formulation. It is a controlled substance, but there's less of the restrictions on how long patients can be on it. There's some data that suggests that maybe it's as effective as some of the GLP-1 agonists, but there's other data that suggests maybe it's a little less effective than some of those GLP agonists. So it would be great to get a head-to-head study in one cohort to be able to determine the efficacy between the agents. But it does appear to be another option for patients that are looking for pharmacologic management. So with that, I will stop my share and turn things back over.